Welcome to the Animal Heartbeat. This is the world's greatest and only podcast dedicated to veterinary cardiology. I am Kieran and Jose.
And I'm Jose Novomatos.
Hello, everyone. Welcome to the Animal Heartbeat. We have with us today Dr. Tommaso Vezzosi. Tommaso graduated from the University of Pisa, then did a rotating internship in the clinic veterinary Malpensa, and the cardiology internship and the cardiology residency at the Istituto Veterinario de Novara, and then a PhD at the University of Pisa. Tommaso is a board-certified cardiologist by the ECVM since 2022. Tommaso, welcome to the Animal Heartbeat. It's a great pleasure to have you with us today.
Thank you so much. I'm really honored to be invited to the podcast, and thank you so much for considering me for the topic of today. Thank you, and also thanks to the listeners.
Well, we have decided to give you a very easy topic today, assessing mitral regurgitation severity, which is one of the hardest things we can try to do, isn't it?
Yeah, thank you so much. So actually, mitral valve disease is a complex. It's a complex topic. It's a complex disease. It's common, but it's complex. Probably, if you ask me to start with a comment, is that probably we should think that we are not facing a disease every day. We are facing patients every day. Because if we think about preclinical cases, B1, they are all different. So B1 have different comorbidities. They have different owners, different compliance, B2, C. So every patient actually is complex and is different. And so also assessment of severity of mitral valve disease is complex from a clinical point of view, from an echocardiographic point of view. So common disease, complex topic.
Absolutely, Tommaso. And what has been fascinating about some of your work is how you have approached the echocardiographic scoring and assessment of mitral insufficiency severity. As all our listeners will know, and similar to many other heart diseases in dogs and cats, many dogs will live with mitral valve disease, or the majority of dogs will live with mitral valve disease, myxomatous mitral valve disease, all their lives without developing any cardiovascular events or adverse outcomes, while up to 30% potentially will develop complications such as pulmonary edema or cardiac death. So to define those cases and to identify those cases that will have adverse outcomes is, of course, really important. So this is part of some of the great work we have been doing in Pisa. If we start with the beginnings and about echocardiographic assessment of MI severity, what are the limitations of relying or using individual echo variables to assess MI severity versus combining variables into a composite score?
Actually, again, from the beginning that we are speaking of a complex disease with different hemodynamic phenotype. So not all mitral valve patients have the same hemodynamic profile in terms of preload, contractility, afterload, right side. So of course, it's difficult to think that just one parameter can be enough. So if we think about left atrial size, that is essential, of course, but left atrial size is an expression of chronicity of mitral regurgitation, yes. My mentor, I remember he told me left atrial size is like fructosamine. So it's an expression of chronicities. It's interesting, but it's not enough. We know that sometimes you have big left atrium with only mild left ventricular filling pressure. So left atrial size, of course, is not enough. Left ventricular size is more dynamics, still express chronicity, of course, but is more dynamics, is more linked to heart rate, preload. Remember, furosemide use or diuretics in general can significantly influence our assessment of the left ventricular size. And then, so remodeling is not enough. We should estimate left ventricular field pressure when we want to communicate the prognosis to our patient, when we want to plan the following rechecks. So as well, even advanced echocardiographic assessment or left ventricular field pressure are not enough. So of course, we need a composite assessment. Composite score is another point that we can discuss. In this term, you referred to the MIND score. Maybe I can share a brief story about the MIND score. MIND score is the mitral insufficiency echocardiography score. The nice story is that the idea started when I was a resident with my co-resident, my mentor, Oriol Domenech. And so we share the idea that the echocardiographic report should finish with a comment on the severity, also in line with human cardiology. So we reported mild mitral insufficiency, moderate, severe, and then we implemented, of course, with the ACVIM classification. And as a resident, I found it really interesting because to speak with owners, you say mild, moderate, severe disease is really communicative and sometimes more communicative than, say, B1, B2. Also for communication with the colleagues, other specialists, other primary care veterinarians, they really nicely understand if you speak to mild, moderate, severe. So I was really attracted to this approach and this method, which was the problem that I found variability among us. So as a resident, sometimes I spoke about mild disease, and my co-resident would have said moderate, mild to moderate. So we decided, why not trying to find a score that help us to be standardized among the group, more repeatable over the follow-up, and helping with the communication. So this is a brief story on the MIND score. And so the process started from trying to select commonly acquired measurements that we are used to acquire in every patient, even if the dog is not compliant, even if the view is not perfect. So this was the idea of the origin of a possible composite score, actually.
And I always think that as cardiology diplomats, we look at so many variables on the echo, as well as the clinical signs of the patient, the history, the physical exam. So we're integrating a lot of things. And this score is a little different to what we do as specialists, isn't it? Who are the audience for the MIND score? Who's it intended for?
Yeah, big point. Obviously, MIND score is a simplification of the echocardiographic assessment of mitral valve disease and severity. But it's something that starts from something that easy to use, that can be used by not only referral centers. If we have time, we can speak more advanced, of course, measurement that we are collecting every day. But we should realize that echocardiography every day is not only something of the board certified cardiologist. Echocardiography is done by non-board certified cardiologists, other type of specialization in cardiology. Now starting is increasing to be a real world, so emergency care is doing echocardiography. So which is the future of echocardiography? Probably is that is a tool of the veterinarian with a training process in cardiology. So now our idea, a simple, easy to use echocardiographic score that also non-board certified cardiology can be used, is useful. Another example is I discussed sometimes that MIND score can help in the follow-up of patients after procedures, after mitral valve tears, after mitral regurgitation. So the follow-up of this patient not always is done by a referral center. In Italy also, the medical treatment, not all the rechecks are done by board certified cardiology. So to have a shared easy to use composite score can help the patients, because remember us that the aim is the patients to easily follow up them, to standardize the assessment. So this can be a possible answer to your point. On the other end, of course, it's limitative. We are considering only 3-4 variables, but is a limitation of what is a composite evaluation of a complex disease in this sense. Yeah.
Tommaso, can you just remind our listeners what are the variables you are measuring and which variables are part of the MIND score? And then, as always, if someone starts looking at papers, they will find different scores, different names. So to make it clear, can you explain us what happened between the MIND score 1 and the MIND score 2?
Yeah, absolutely. So the echocardiographic variables, considering the original MIND score that was published in 2021, we selected 4 echocardiographic variables, so commonly used, recognized by the ACVIM guidelines, and demonstrated to be prognostic indicators by different research groups. That was one of the criteria to select the variables. So demonstrated to be prognostic by different research groups. We selected the left atrium aorta ratio as left atrial size as a traditional measure for left atrial size considering the guidelines. Then we selected the left ventricular internal diastolic diameter normalized for body weight as an index of left ventricular size. Then we included the fractional shortening on the left ventricle. And if I have time, I would like to discuss a little bit on this point. And lastly, the peak velocity of the E wave in the transmitral flow. Comment on fractional shortening, I would like to do that because some colleagues ask, why did you consider fractional shortening mitral valve disease that is strongly log dependent? So the idea was to include a fractional shortening not as a parameter of systolic function, of course, but as an indirect expression of regurgitant fraction. Because if we think fractional shortening is an expression of total stroke volume, and different papers from different research groups demonstrated that higher is the fractional shortening, higher is the severity of the regurgitant fraction. And if we think about the population in which the MIND score was published, that is small breed dogs. So remember, we should apply MIND score 2 to dogs less than 20 kilograms. In this population, as we know, dogs go in congestive heart failure and die in congestive heart failure with an hyperdynamic left ventricle. So higher is the fractional shortening, higher is the severity. That's the reason why we included the fractional shortening. Why higher it is, higher is the severity. On the other end, of course, fractional shortening is not regurgitant fraction. Fractional shortening has many limitations, is strongly load dependent. It depends on the sympathetic tone. So, of course, has many limitations, but the idea was that one.
I can see why it's controversial, but we use it subjectively. We will look at the heart, and if it looks like it's got a huge fractional shortening, it's very hyperdynamic. There's a lot of blood going backwards, right? Because of the severity of the MR. And we look and we say, "Ooh, it's really hyperdynamic. Must be bad MR." Now, I know the limitations. I appreciate that in bigger dogs, there may be more of a component of systolic dysfunction. And I appreciate that in more advanced disease, you end up with reduced function, which will reduce how dynamic the ventricular motion is. But still, we do eyeball it, so I can see why it was in there. What was the rationale for taking it out for MIND score 2? Was this because of the controversial nature of it, or a lack of repeatability, or did it not influence things as much as the other parameters in the score?
Yeah, absolutely. So let me anticipate the concept death. The reason why we included all four variables in the original mind score was not out opinion, but was because they were all independent predictors of cardiac mortality in the multivariable analysis. So it was not opinion to select and to include in the score. Differently, in the MindScore 2, that was the second study on the topic, only including preclinical or pre-symptomatic dogs, as one would like to say, that's different because we still include all the four variables, but in the multivariable analysis, the fractional shortening was not an independent predictor. But in my mind, it's reasonable because fractional shortening in the preclinical stage express less the hemodynamic profile that is in the congestive heart failure stage. So we realize that we can simplify the score, but not because the fractional shortening has not sense. Has sense, but is more useful if you consider the C and D stage, so the congestive heart failure stage. If we consider preclinical cases, actually can be a significant confounding factor, because looking at the original my score, we had some B1 dogs with like 60% of fractional shortening, but just because they were excited, afraid. So in that sense, we risk to increase the judgment of the severity of the disease, but just because the fractional shortening has some limitation. So for this reason, in MindScore 2, we take off the fractional shortening.
You mentioned there that the MindScore 2 then addressed more the subclinical dogs. And again, regarding how shall people use the MindScore in everyday practice, would you say that the MindScore is more useful in subclinical cases to predict the risk of congestive heart failure, or more useful in stage C cases to predict cardiac death, or in both stages? So what would be your recommendations for a practitioner that is looking at mind scores? Is that more useful subclinical, clinical, or across both stages?
Yeah.
Controversial question. Do you think we should be using it instead of stage B1, B2C?
Actually, the original mind score included all the stages, so B1, B2, C, and D. And we have been using the mind score for all stages. After publishing mind score 2, that included only preclinical cases, we actually realized that the mind score is particularly useful in the stratification of preclinical dogs. But every day, if you ask me what you are using in clinical practice, we use mind score 2 for all patients, also for dogs in congestive heart failure, because mind score 2 as well described again a hemodynamic phenotype. So it works as well in dogs with congestive heart failure. So now we are not using the original one, but B2, mind score 2 for every patient. And maybe if I can comment of this, what we discover over time is that the original idea was that the score can be useful to say mild, moderate, severe, right? Or late stage, because remember there is a late stage class that is interesting because are those really with a really bad prognosis that can have clinical implication. Anyway, apart from that, my point is that what we discover is the importance of the numerical score. So there is a difference between 3 and 4. There is a difference between 5 and 6. And a variation of the numerical score over time means a significant hemodynamic change in the patient in our experience. This can be seen after interventions like mitral TEER or mitral valve repair, but also with mitral medical treatment. If you see a movement of the numerical score over time, it has a strong indication that the dog is getting better, is getting worse, and it means an attention. So sometimes you remain in the same class, in the same severe class, but if you move from 10 to 7, it's a big message for the patient, for the owner, for the management of the patient. So in this sense, I think that the inclusion in our reports, not only of the severity class, but the numerical score is something that is really helpful every day. Yeah.
So how the mind score compares with the ACVM staging. So especially because everyone, and we have discussed that several times in the podcast, B2 is a very heterogeneous group, and there are dogs that have mild B2 and more advanced B2. And so maybe just calling them B2 will not reflect how bad or the disease is. So based on your data, how does the mind score compares with stage B1 and B2 if we talk about subclinical disease, and what's the advantage really? What can mind score give you additionally to just classify the case as B1 or B2?
Yeah. So the point is that I would like to remember that ACVIM is a clinical classification. So it considers history, physical examination, echocardiography, chest X-ray, blood pressure, etc. Mind score is an hemodynamic and echocardiographic classification. So mind score can be an integration of the ACVIM clinical classification, is integrative. What we see is that it helps stratifying the risk among the ACVIM classes. And this was demonstrated in the paper because, yes, maybe start from the B2, but then if we have time, it's interesting to speak about B1 because B2 is an heterogeneous class. Of course, we know that some B2 die of tumor after 4 or 5 years, all right? Some B2 die of congestive heart failure in few months. So they are really an heterogeneous class, even if remember that the mind score 2 demonstrated most of them are moderate disease, all right? But actually there are severe cases, what we refer to advanced B2. This is an important point to me to discuss. So many of us speak about advanced B2, that advanced B2 maybe need additional diagnostic test, maybe they need additional treatment, etc. But actually, anyone has produced a consensus definition of advanced B2. So most of us speak about every day of advanced B2, but each one has a own definition of what is advanced B2. So one of the aim of the paper of MindScore2 is actually try to define what is advanced B2. And we propose a definition that in clinical practice we call advanced B2 those B2 dogs that are classified as severe with MindScore2. So using a numerical score from 7 and up. So this is the first comment that B2 should be, in our opinion, stratified with the score. We use MindScore2. You can use other techniques, but we need to stratify. This is clear to many cardiologists. And this is important because probably in the future we should ask us, management of mild B2 is the same of moderate B2, management of severe B2 that has a demonstrated different prognosis from moderate ones should have the same management. So this is a big question that probably we should take in mind. And MindScore can be a proposal to start with a a commonly shared definition, because if we want clinical trials on that, because a big question can be, some cardiologists think that advanced B2 need diuretics, all right? Well, actually, we need to perform a clinical trial demonstrated that advanced B2 benefit from diuretics. But if we don't have a shared definition of advanced B2, we are even in the earlier stage of the process. So yeah, that's my point of view on what we are actually. I don't know if I answer your question.
I think agreeing what we're talking about is sometimes difficult, isn't it? And if we're saying, oh, an advanced B2, I think most experienced diplomats would say, okay, I think I know what that means. Maybe it's not the same thing, and therefore standardizing it is always beneficial. I think that using MindScore for me has only really come along since I've wanted to assess the effective intervention and track cases. For me, for talking to referring cardiologists, it's also very useful because everybody with different levels of experience, different levels of qualification has a different definition, as you say. So I think standardization is critical to making decisions for the patient and providing the right advice, even away from the prospect of research. In humans, what would they do to assess mitral regurgitation severity? Is that something we should be aiming for to mimic the human system? Is that practical in veterinary medicine?
Yeah, yeah. I agree that I find human cardiology really practical. That's a big point. So, for example, for many years, they are used to report from an echocardiographic point of view, mild, moderate, severe, and their definition is strongly standardized in the papers and the guidelines. So they include in the definition the morphology of the valve, of course, remodeling, so left atrial size, left ventricular size, but also qualitative, semi-quantitative, and quantitative assessment of mitral regurgitation that include many parameters. They include assessment of left ventricular filling pressure. So not only E-wave velocity that is included in my score, of course, they consider, but what we are already using in dogs, so EVRT, E prime, so tissue Doppler, pulmonary venous flow. So there is an advanced diastolic study of mitral valve disease in humans. So in this point, we are ready, and we are using most of these variables. Quantification of mitral regurgitation is more questionable in veterinary medicine. For many years, we used the subjective assessment of color Doppler in comparison to the area, for example, but this is risky. Actually, human guidelines underline that this technique can be really unprecise, and so is really subjective, is strongly dependent on the settings of the machine, on the patient, on the alignment. So probably is not the best way to assess the severity. Different in some semi-quantitative measurements. So vena contracta, for example, is another parameter that is used in humans and is also described in different studies in veterinary medicine. Then we can use regurgitant fraction. So there are different papers, even recent, that are considering regurgitant fraction in veterinary medicine. Regurgitant volume is another aspect that can be considered. Of course, we are going to speak about more advanced measurements. And so we should take in mind our variability, intraoperator and interoperator variability of each measurement that we select to put in our minimum database. No, probably each one has a own minimum database in mitral valve disease, but probably depend also on the experience, because to increase the number of variables that you want to collect in each patient can complicate the exams. Of course, it depends on the compliance of the patients, the quality of the echocardiography, etc. So this is something that should be considered. And probably we are a little bit back in comparison to human medicine in terms of evidence of using such kind of variables. And again, different papers are coming out on these topics. And probably in the future, we need a consensus on the echocardiographic assessment, especially mitral valve disease.
What is interesting about mitral insufficiency assessment and echocardiographic assessment is, of course, there has been a huge push now for us to improve assessment of mitral regurgitation after minimally invasive techniques or hybrid techniques such as TEER procedures have become more common and are developing so fast. So I think that's interesting because that's pushing certainly the way we assess mitral regurgitation and the need to become better at assessing mitral regurgitation severity. And as you mentioned, regurgitant fraction would make a lot of sense, because if you are looking at LA size and LV size are surrogates of mitral insufficiency. So if we can really quantify how bad the mitral insufficiency is, that makes a lot of sense. But as you said, the problem is the variability. But I think it's really an interesting field at the moment that we are all trying to become better at detecting and defining mitral regurg. What I wanted to ask you is regarding regurgitant fraction, because that's certainly the low-hanging fruit, and based on the criteria from the Colorado State group, and we should probably start looking at regurgitant fraction more carefully for TEER patients and so on. Have you been using regurgitant fraction in your clinical practice, and have you tried to add regurgitant fraction to your MIND score? It would be interesting to see if you would add regurgitant fraction to your MIND score, if that would improve the prognostic capacity of the score.
Yeah, so we are using regurgitant fraction actually every day in our mitral disease patient. Let me comment on that. First of all, which technique we are using. So we are using the volumetric methods. So we need, first of all, to calculate the total stroke volume. That in the volumetric technique is commonly used the Simpson method of disc. From that method, you calculate the total stroke volume. Then you need to calculate the forward wall flow, so that you can, of course, calculate the effective regurgitant fraction, so the amount of blood they actually come back to the left atrium. Let me comment on what I found in the papers and why we are using what we are using every day. Because volumetric methods needs, first of all, to decide the view. So in different papers, you find that you can use right parasternal long axis view. Some papers describe from left apical view regarding volumes. Another point is, how do you assess forward wall flow? So some papers say that you use the subcostal view, and it makes sense because we know that subcostal view is the best alignment that we can get in dogs from many papers in subaortic stenosis, etc. So it's reasonable. Is it possible to acquire subcostal view in every patient? Not necessary. So this should be analyzed. And in different papers, again, not all authors use the same technique. Another point that we should analyze is where you put the sample volume of the pulse wave Doppler. Because some papers describe, and it is what we use, to put the pulse wave Doppler and the sample volume at the level of the aortic valve, so the hinge points. This is reasonable because actually it's the point in which you measure the flow coming out from the left ventricle. Other paper describe to put the sample volume at the tip of the open aortic leaflet. Is different. If you try measuring the same velocity time integral at these 2 points, you get different numbers. Another paper from another research group say to put the sample volume at the sinotubular junction. That is much lower and you get different values. So we are everyone is speaking about regurgitant fraction, but my first question is, are we using the same technique? Are we comparing the same values? So technique should be standardized probably, because before adding, for example, regurgitant fraction to a MINE score, first of all, we should standardize probably the technique. And MINE scores, the idea was to select traditional measurement, commonly acquired, everyday experiencing that. So our fear is that if you add a measurement that we still not know how much is the reproducibility, the variability among operators. Let me comment on that. If you look at the last papers coming out from different research groups, they do not agree on repeatability and measurement variability. Some papers suggest a high reproducibility and high measurement, a good measurement variability. Another group suggests that the reproducibility and measurement variability is not clinically acceptable. So where is the truth? Probably is in the middle, but probably we need further studies. And let me another comment. When we look to variability in our studies, they are produced by researchers, usually board certified, that share that measurement. And so are those values of reproducibility and variability applicable to the real world, to all clinicians? Second point, variability depends on how many times you do the measurement every day. Because you can say left atrium aorta is not perfect in terms of variability. This is a big topic, right? But we are measuring
That's the whole of the podcast right there.
Exactly. So we are measuring for 20 years every day. So I think that variability in the papers not necessarily reflect what happens in the real world in terms of clinical practice. I don't know if you
No, totally, absolutely, I totally agree.
Sure.
And that's my concern exactly, regurgitant fraction, especially when we measure. It's not so much, I think, as it has been shown, the variability is not so concerning on how we calculate the volumes with Simpsons. Is of course how you calculate the forward flow, because that is when you of course calculate
that's the biggest variability.
that's
there,
the basic variable. Exactly.
Pi r squared.
Exactly, you're going to square your mistakes, exactly, your errors. So that's exactly the concern. And as you said, of course, if you look at groups that publish research in this area, these are highly specialized cardiologists working in a very close echo lab. But that's when I look at data from Dr. Oyama's group on JVIM, where they had 2 operators, highly experienced, expert, qualified operators measuring regurgitant fraction in normal dogs. And their variability was so high, makes me very worried about using regurgitant fraction in clinical patients. And so I totally agree. But I guess the problem, that's why I mentioned the TEER procedure, and Kieran can of course comment on that much better than I can. But the issue is we need something that assess acute hemodynamic changes. We need a variable that mirrors and shows what has happened with the procedure in the first few days, weeks, months. And of course, reverse remodeling takes a long time to happen. Certainly, LA size, LV size are surrogates of mitral regurg and are more are better parameters because they are very real. But if we want to monitor what has happened acutely, is hemodynamically happening with the mitral valve, we need to calculate regurgitant fraction, right? We need those kind of variables. And so I think there's a clear need to measure the regurgitant fraction. It's just concerning how much the variability is. Kieran, can I ask you a question? What has been your experience with regurgitant fraction when you monitor your TIR cases over time?
I mean, wind back the clock a few years before we got interested in minimally invasive mitral valve repair. And when I was working in a university teaching hospital, and I was doing a terrible job because I said to the students, it's all about chamber size. It's all about chamber size. All we care about is chamber size for decision making in preclinical disease. And then once they're clinical, well, they're clinical. Who cares about chamber size? They're clinical. So I have learned a lot. My viewpoint has changed a lot in the last 5 years. The strange thing about doing a podcast, let me just frame this answer, is that people tell me what I think. Oh, well, you think this, but I disagree, which is interesting. I don't know if you found that, Jose, but I have people come and say to me, yeah, you don't like spironolactone. Well, I mean, I do. But people come and tell me what I think. And I had a French colleague say to me, what's your problem with Pisa? and I said, maybe I'm just not as good as you guys are. Because if you look at the papers out of the French group looking at Pisa, proximal isovelocity surface area for assessing the regurgitant orifice area, the mitral regurgitation severity using Doppler-derived methods, they get great repeatability compared to what I get myself. So, so I don't use Pisa. I do use volumetric methods. My colleagues and I have become more repeatable with one another. Our inter-observer variability has reduced. Doing it more and also sitting and doing it together, and being very selective about not foreshortening the ventricle in your. We use the R-Plax view for the right parietal long axis view for stroke volume, total stroke volume. Being really, really selective about the aortic diameter to derive your forward stroke volume. And as you say, being really conscious of cursor positioning for the aortic forward stroke volume VTI. Even with that, we still get some variation. It's part of the picture for me. It would never be a decision maker. I would never look at a dog with a normal size left atrium and say, oh, well, I'm measuring a regurgitant fraction of 70%. I mean, first of all, I'd be very surprised if those two things went together. But I would never say your dog needs surgery because it's got a normal size left atrium. So before we even look at regurgitant fraction from a perspective of performing TIR, we look at the patient, we look at the standard echo variable, and more we do look at the MINE score. We're categorizing or subclassifying B2 using MINE before we ever see the dog. This is from a referring cardiologist who sends a case to us, and we'll review their data, their echo data, and we'll look at MINE score and say, okay, yeah, it's bad. It's bad enough. And we take that as a baseline. And then we might assess candidacy. And during our candidacy assessment, we will make an estimate of regurgitant fraction based on volumetric methods. And I emphasize estimate because it's not a measurement. It's an estimate of regurgitation. I remember Lance Visser on maybe season 1 of our podcast talking about echo assessments and saying it's an estimate of a presumption or something along those lines. And that really resonated with me for these complex echo methods. So what we're seeing with TIR, for anyone who's interested, is that we're getting dogs going from 65, 70, even 80% MR fraction pre-procedure. Our target is to get them below 30 based on the data from Colorado. We are mostly doing that. Not always. Sometimes we get them to 43. We had one over 50 still. And these reflect the severity of the disease and the dog's anatomy, which makes it more challenging. But what we're identifying is that on day 2 post-TIR, we're seeing the regurgitant fraction estimate drop. The chamber size is often a little smaller on day 2. Week 4, week 12, we've got some dogs now 6 months post-procedure. For the dogs where we're getting below 30, many of them are getting progressive remodeling, but their MR fraction is the same as on day 2. So on day 2, we're able to say the MR fraction today is this, and therefore we're super happy with the result. We would anticipate there being reverse remodeling based on our experience. We've done 15 cases right now at the time of recording, so not many. We're not super experienced, but we are observing that even with the pitfalls associated with it, an estimate of MR fraction is useful for those dogs. It is not the solo measurement that we're using, and we would not stop diuretics based on MR fraction on echo.
Yeah, absolutely. I think that's the point is we don't need to integrate advanced echocardiographic measurement in the score. All right, so
because that's not the point of the score, right?
Yeah, that's an easy to use tool to stratify the risk, etc., to follow up, as you said. Then referral center should decide which advanced measurements should be used. Regurgitant fraction is strongly interesting, I think, but we should standardize the acquirement, set up the cutoff, because the proposed cutoff in the literature is to define severe dose with a regurgitant fraction of higher than 50%. But actually, in our practice, and also looking at recent papers, one from the group of Serena Crozara, the other from McCloy and Mark Rishnio, actually seems that severe patients starts at a level of higher than 60% most of the time.
I feel the same way. I've limited experience compared to those
so
groups,
from 50 to 60% is a gray zone. From 60 and higher is really severe. And so there are different proposals. And remember that also the Doppler method is appealing. Some research group calculate the regurgitant fraction with the Doppler method. So they calculate the velocity time integral of the mitral inflow, and then the 4-to-4 flow as the other method. And some papers suggest, for example, from Colorado, that this technique can also be better in a certain way. So probably, we should standardize how to acquire regurgitant fraction. If we really need regurgitant volume, this is another topic, or maybe not. Because I think that regurgitant fraction can help sometimes to better stratify also preclinical dogs. Because in the previous question, I referred to B1. B1 dogs actually now are heterogeneous. Actually, based on the last ACVIM guidelines, if you think about that, you can have B1 dogs with enlarged left atrium and normal left ventricle. This is not a huge percentage, but they exist. And are we sure that those B1 dogs with enlarged left atrium have the same prognosis? Should be managed in the same way of B1 dogs without left atrial enlargement? Some years ago, we published a study on that, and we demonstrated that those with left atrial enlargement with normal ventricle have a different prognosis. We don't know if we should treat differently, but they have a different prognosis. So mean score in this sense, or fractional regurgitant fraction, can help to stratify also B1 dogs, actually, at least at this time, because they are not all the same. This is probably another point. I don't know if you agree on that.
No, totally. That's an important point that you raised there, and that paper you mentioned was a really nice paper to look into that. Especially because I think that's a question that comes up in the clinic every day. You have dogs that would suit fit one of the stage B2 criteria, but not the other one. The LA size may be already dilated and would fit B2, but then the LV size is normal, or vice versa, as you said. And I guess it will be, in fact, I think it would be interesting to know what cardiologists do, because I think people have very different approach. Some people will be more defensive and say that doesn't matter. We still wait. There's still a lot of time for the disease to progress. There is no urgency to start pimobendan, while others may think, why not? Will not harm the patient, and this may be already a case that is going towards B2 and will start an intervention or medical treatment already. So I think that's an interesting group indeed. But looking at what you just said, and those are really the interesting cases where LA size is dilated and LV is normal. I think on your paper, that was the highest percentage of cases had LA dilation with normal LV dilation. So the other way around is less common. But then also a MIND score would be mild in those cases, right? Because if you are talking about the LAO of 1.7 to 1.9 or something like that, that would still give probably a score of 4 or something like that. So the MIND score would also not detect those cases with mild LA dilation. Is that right?
Yeah, absolutely. So actually, to call moderate B1, usually you should have a big left atrium. It's rare, honestly. So, but you have patients with 1.9, 2 left atrium aorta value with normal left ventricle. Of course, you have to integrate other measurements to characterize the hemodynamic phenotype, but it's hard to think that a dog with the left atrium aorta ratio of 2 has the same prognosis of a normal B1.
So what do? You see a dog today at the University of Pisa, and you have an LA of 1.9 and a normal LV size. What do you do with those cases? Do you monitor them? So what's your approach? What do you do with such a dog?
Yeah, absolutely. So, of course, I would like to take a look at transmitral flow, diastolic function, because of course, if there are other indicators of risk of congestive heart failure, I would avoid just recheck the patient. In some patients like these, we start pimobendan. So yeah, if I have a dog with a left atrium aorta 1.9 or 2 with normal left ventricle, we usually start pimobendan. But it's important to ask us why the left ventricle is normal. Which measuring are you considering? Remember, the linear measurements have limitations. So now we have reference value for volumes. Or we have normal left ventricular dimension because the dog is under diuretic or has received diuretic, or, so we have to consider why this dog has big left atrium with normal left ventricle. So this is a big question that we should ask ourselves before taking a treatment decision. So it can be different explanation. In humans is a recognized entity to have enlarged left atrium with normal left ventricle, aging of the ventricle, fibrotic evolution of the ventricle. So different explanation can be done. But I think that pimobendan can be considered if there are other indicators of severity, I would say.
I think one of the common situations I've seen that gives rise to that is either the aorta is small for some reason. You've got a hypoplastic aorta, and therefore, of course, your LAO is elevated, but your normalized left atrial diameter for body weight wouldn't be. The other thing would be an obese patient, where the LAO, you're standardizing to aortic size, whereas the LVIDD, you're standardizing to body weight. And if they're obese, you'll make it look more suitably sized for the patient weight than you would do otherwise. So that, for me, that I think can give the mismatch. The alternative situation that I think we sometimes come across with that B1, B2 decision is some male cavaliers have a huge aortic root. And therefore your left atrial size, LAO, is normal, but your LVIDD might be 1.92. And actually your normalized left atrial diameter, if we go on Visser's normalizing factor, which is what we do in our clinic, might be over 2 or 1.9 or something, with the reference being up to 1.56. So I think those are the situations we might come across. Rather than it being a disease difference, it's often a technicality.
Yeah. And also we should consider systemic hypertension.
Sure. Yeah.
Because it's common in our patients, and so you can have dilation of the sinus valsalva, and so it falsely decreases the ratio. In this sense, we are maybe what we are considering for the MIND score is an integration of the left atrial diameter obtained from the right parasternal long axis view. That's a measurement that we love, that we trust a lot. Probably at this moment more than volumes. So left atrial volumes is really appealing, is gold standard in humans. But even on this point, variability is something that we should go in deep, because as you know, different research group use different techniques, biplane, monoplane, Simpson, area length. So volumes at this time is really interesting. We use in everyday practice. So we assess left atrial size always with 3 measurements: left atrium to aorta ratio, left atrial diameter from the long axis, and left atrial volume, because we want to see if all these variables go in the same way, suggest the same indication. All of them say enlarge, 2 up to 3 and say enlarge. So in our practice, we found really useful to integrate the assessment of a fundamental chamber like the left atrium with at least 3 measurements. In this point, we are considering to integrate the left atrial diameter in the MIND score. It's something that we are considering, but because the left atrial diameter is repeatable, is reliable in terms of low measurement variability. So in this sense, it's something that we could consider.
And I think going right back to the very beginning of our conversation, we need to keep things straightforward so that this is an achievable score measurement for people of different levels of experience, so that we can all speak the same language. Because I think the 3 of us have got sufficient experience to do some more complex measurements, and to do that estimate of an assumption with some repeatability. And I think the more exacting we make these measurements to try to make them better, in inverted commas, maybe we put them more out of reach of the people who are going to be doing more echo than we do in the emergency room, in primary care practice. I think what we need to do is try to keep it achievable, and not just achievable, but sort of repeatable for the majority, rather than put it out of everybody's reach again. And that's one of the reasons I really like the MIND score, is the simplicity of acquiring these things for someone with a bit of echo experience means that we can speak the same language. And I think that can be incredibly useful when it comes to these collaborative decisions for patients.
So for someone that after this podcast will go, well, now I'm going to review the literature about mitral insufficiency scores. They will find the MIND score 1, the MIND score 2, and now the Minerva. So what's the difference between Minerva and MIND score 2? We had Mark Rishnu here in the podcast a few months ago, and he briefly touched on that. But if I remember right, the Minerva use exactly the same echocardiographic variables, but they have changed the cutoffs to define the different categories. Is that right? So how different is do you use the Minerva cutoffs? I'm not sure the paper has been published yet, or do you still use your MIND score to cutoffs? And what's the difference for the practitioner out there? Which score should they be using?
Yeah. Thanks for your question. So the point is that, as you know, Mark Rishnu is co-author of the MIND score 2. So we share the original idea of MIND score 2. And in fact, actually, the Minerva score is a similar idea that confirm that and demonstrate the MIND score 2 is probably a good idea, that we need to stratify these patients. Similar idea because there is in the score the same variables. Mark proposed a variation of the cutoff all right? And these produce a different prognostic profile of the patients. This is important to consider, and it explain why we are using MindScore 2 in clinical practice and not Minerva. The reason is that if we look at the Minerva mean survival time for severe preclinical dogs, it's 8 to 9 months. So it means that you have an advanced B2, you are going to say your dog is severe and is going to die in 8 to 9 months, all right? Differently in MindScore 2, because if you look at MindScore 2, the median time to cardiac event, that is usually cardiac death, for severe patient is 2 years, around 2 years. So this point is a different point of view of what is the prognosis. So in our experience as a clinicians, what we say, if I have a dog that is doing well, because it's preclinical, and you say is going to die in 2 years, is severe for us. Because a dog that is going to die in 2 years, it means that will develop congestive heart failure, start advanced treatment, consider tears, rechecks more frequently. So it's hard to think that I communicate the same prognosis of an advanced B2 and a congestive heart failure patient, because we know that congestive heart failure patient have a prognosis of 9 months, 1 year. So tomorrow I'm going to say, okay, you have the B2, advanced B2, prognosis is 8 to 9 months. And the other dog that is hospitalized in congestive heart failure, you say, okay, you can go home with the treatment and you have the same prognosis of a preclinical dogs. So in this sense, we keep going with the MindScore 2 because in our experience as clinicians, we find MindScore 2 prognostic profile more close to clinical practice. So if I have an advanced B2, I'm confident to say median survival time is around 2 years. If I have a congestive heart failure dog, I usually say it's around 1 year. So it's a different message, and this is the reason why. On the other hand, we should consider that we are comparing different study population, because in the MindScore 2, we have around 700 dogs and around 80% of B2 receive pimobendan. In the Minerva score, essentially no B2 cases receive pimobendan. So of course, we are comparing different population in this sense, all right? Briefly, I've tried to explain why we are still using MindScore 2. So the original idea that we also share with Mark, probably the final message on this point is that we are going together, different groups, saying that we need a practical score to stratify our patients. So this is the big message, and we all agree on that. Different scores have different prognostic profile, etc. That is also linked to the clinical experience of each research group.
Based on that change in the mind score, in a dog who is on furosemide, pimobendan, in congestive heart failure or previous congestive heart failure, if the dog is clinically stable, so respiratory rate is the same, the exercise is unchanged, but the mind score has increased, would it change how you treat the patient or just how you talk to the owner about what to expect?
Yeah. This is a typical scenario. I agree. Probably is more common in the C and D stage. The patient is doing well, is under treatment, but maybe from a consultation to the other one, there is an increase, especially. Sometimes decreased. In this sense, usually we assess if the diuretic dose is too high sometimes, and sometimes so we evaluate a possible reduction, of course, considering clinical picture, physical examination, blood exams, renal function, of course. But sometimes we have reduced diuretic dose based on a variation in the MIND score. In the other sense, so if the dog is stable, but we have an increase in the score, again, we are used to going deep, trying to find the reason of this increase. And sometimes we change the treatment. Sometimes we increase the dose of vasodilators, we increase the dose of ACE inhibitors, spironolactone, sometimes diuretics. Sometimes we recheck blood pressure to be sure that everything is stable in that sense. So not always, not always. We change treatment if the score is changing, but many times I would say.
Interesting.
Tommaso, considering those changes over time, have you ever looked at the MIND score reliability and variability? What's the reproducibility, repeatability, and variability of the MIND score, for example, within your group?
Yeah, good point. So obviously is linked to the variability that we have with the single variables. So the variability of the MIND score depend on our variability with the left atrium to aorta ratio, that usually is the higher one. Left ventricular and internal diameter, the variability among operators is really low. And as well, the wave variability is not the problem. Left atrium to aorta ratio interoperator is significant, not in the same center. So in the recheck of our patients, we don't find it really significant. But when we recheck patients, maybe from other centers or non-board certified, actually the variability in the left atrial to aorta ratio can be significant. But what is interesting in the MIND score is that you have a range. What I mean, if you take the left atrium to aorta ratio, you have from 1.7 to 1.9, for example. So our experience is that even if you have variability, but usually you remain in that class. So even between operators, the total score remain the same because the variability, that can be 10% sometimes in the left atrium aorta, but it means that you change not so much to change the class and the score. You know what I mean?
Yeah. No, that makes sense. Makes sense. Brilliant.
So Tommaso, we could keep talking about this for a long time, I'm sure. And the more we talk about it, the more controversial we're going to be, I'm sure. But we are probably at the end of a reasonable time for a podcast. So I wanted to say thanks for joining us. It's been a real pleasure and really thought-provoking.
Thank you very much, Tommaso, and keep up the good work. I think your research group is doing really, really good work, and it's always very exciting to see what you guys are doing and to read your papers. So yeah, well done, and keep up the good work. And maybe in 2 years we're going to discuss about the MIND score 3, or 4, or 5, or the super MIND score. I don't know.
The Minecraft score.
The Minecraft. Yeah.
That's what my kids want.
We'll see, guys.
Much,
Thank you so much. Really honor again to be with you, and still really, really excited to be here. Bye.
Right.
Take care. Thanks so much. Bye.
You have been listening to the Animal Heartbeat. If you'd like to reach us, email us on animalheartbeat@gmail.com.
Remember to like, follow, or subscribe wherever you get your podcasts, and check out our website, animalheartbeat.com.